All right, welcome everyone to session 16. Can you believe it? In our 2024 webinar series, Empowerment Through Education. I'm Julia Wood, the Director of Professional and Community Education here at the Lewy Body Dementia Association. And today we're going to be learning about swallowing difficulties in LBD and how to treat and cope with them. So let me see if I can get these to go forward here. So this is our presenter. I'm so excited. I'll introduce her and give you a little bit more information about her in a moment, but we're going to have Dr. Darla Freeman joining us, and she'll present until around 3:20 or so, and then we'll take some questions from the audience from about 3:20 to 3:40. So, before I get started, a few words about us here at LBDA. We are a nonprofit dedicated to optimizing the quality of life for those affected by Lewy body dementia. We provide comprehensive education for the community and professionals, deliver compassionate support for those living with Lewy, and strive to advance awareness and also research efforts. So a few housekeeping items before we get started. You'll want to maybe take a moment to get acquainted with your Zoom toolbar. So usually if you hover at the bottom of your screen, if you're on a computer, if you're on an iPad, it might be more at the top of your screen. You'll see where you can select show captions on your toolbar at any time. And this will allow you to launch closed captioning. There's also a resources icon at the bottom on that same toolbar, and you'll notice that this has links that you can select as well as downloadable resources. We've made those slides available for you today, and there'll be some other links probably thrown in there throughout the presentation. And then you are also welcome to submit any questions that you might have throughout the presentation using that Q&A icon. And then following the presentation today, we'll take a few of those questions from you. So, some exciting news. We now have a nice little banner on our home screen where you can access the page to register for upcoming webinars, or also you'll notice our LBDA TV site where you can watch recordings of past webinars, and you will be sent a link for today's recording in about 1 week with those resources as well. And then lastly, when you leave the session today, a brief survey is going to appear asking for your feedback. Please take a moment to fill that out for us. It's helping to inform our content for 2025. All right. And then lastly, I just want to remind you all that if you have specific questions, if you need support, please reach out to our Lewy line at 1-800-539-9767, or you can email support@lbda.org. This is your lifeline to answer any questions you might have, learn about our online Facebook groups, learn about support groups that might be in your area, or anything else that you may need. All right, so with that, I'm going to stop sharing and we'll learn a little bit more about who's in our audience today. So Rose is going to launch that poll to see who's here. We might have, usually our care partners are kind of number one, but then we also have some people with Lewy, typically some healthcare providers. All right, those care partners are out in the lead as always. We'll take a couple more minutes to let everyone get a chance to answer. Excellent. So it looks like we've definitely got, a little over 60% of our audience are care partners, and that includes spouses. And then we've got around 30% people who are living with LBD or have LBD symptoms. We've got some former care partners in the audience. Welcome. About 10% are healthcare providers. Have a feeling maybe some speech language pathologists out there too. And then some family and friends. So thank you so much, all of you, for joining us. Show that for a second so you can see. All right. And now with that, I'm going to take a moment here and introduce our presenter. So, Dr. Darla Freeman is a speech language pathologist who's been treating voice and swallowing disorders for over 25 years. She earned her doctorate degree from Northwestern University with a research focus on factors influencing successful behavior changes in adult intervention. She is a scope specialist offering state-of-the-art voice and swallowing evaluations and evidence-based treatments in Tampa, Florida. So she's in the path of the storm, you guys. We hope everything is going to hang in there today. Dr. Freeman joined the Parkinson Foundation team training faculty in 2016, which is where I had the pleasure of meeting her. We were both newbies to the group and got to work together. And she's educated patients, caregivers, and professionals through online and in-person presentations. Dr. Freeman was invited to speak at the World Parkinson's Congress in Kyoto, Japan, and Barcelona, Spain, on topics focusing on communication and swallowing disorders related to Parkinson's and atypical Parkinson's disease. Dr. Freeman currently practices at the University of South Florida Voice Center and Florida ENT and Allergy Voice and Swallowing Center. Welcome, Dr. Freeman.
Thank you, Julia. It's so good to see you, and I'm so excited to be presenting today. I'm going to go ahead and start with sharing my screen for everyone.
I'm going to let you take it over.
Okay, thank you. Okay. Well, welcome everyone, and I am just so delighted and excited that I was asked to come and talk to you on the topic of swallowing. And so as you see here, I titled Sip, Swallow, and Support Managing Dysphagia and Lewy Body Dementia. And these are my relevant financial disclosures and relationships, and as well my non-financial relationships. So what I would like to happen today as I finish this discussion, and I really like to say it's a conversation because it's you getting to know about swallowing, me getting to know about you, and offering good information. I want you to walk away from this presentation being able to share with others what dysphagia is and how you could share with someone that you know either you have it or you don't. I also want you to be able to walk away saying, I know why I have dysphagia, but more importantly, who is going to take care of me because I have a swallowing disorder? So who evaluates and treats dysphagia, and what can I do to manage it? What can I do more about it? So we're starting with our first survey question. It's always something curious for me. I want to know how many participants have seen a healthcare provider for their swallowing problem. So we're kind of almost at a half and half here. Amazing. I think no is sometimes seems to be pulling up. Okay. All right. So talking almost about 60% with no and 41% with yes. So it seems like we're almost about the same. Okay. And then of those who have said that they've seen a healthcare provider for their difficulty with swallowing, let's see if I can move to the next slide here. We have another poll, and that is, have you been evaluated or treated by a speech language pathologist for swallowing problems? Okay. So it looks like, again, we're edging up more on no than yes. So about 63% with no, 37% say yes, they have been treated by a speech language pathologist. Okay, great. Thank you so much for participating in that. Okay. So we're going to start this first segment talking about what is dysphagia and how do you know if you have it. What I'd like to talk to you about is how we define dysphagia. We want to talk about the signs and symptoms and then discuss problems that are related to dysphagia. So I'm going to take a moment and we're going to be talking about the process of swallowing. I'm just going to get a pointer up for our reference. Okay, you may also hear the term swallowing being called deglutition. And what I think is amazing about our body and about our anatomy is just how muscles work. And to swallow, it involves a combined effort of over 30 nerves and muscles just to perform this process. And you'll learn soon that it's a relatively quick process. Both we're using reflexive and voluntary movements, which means reflexive, it's going to happen voluntarily, something that I am just going to in the process of swallowing. Now, this will involve three sequential and coordinated phases of swallowing. And we've referred to those phases as you see here. Number one, the oral phase. Our second phase is the pharyngeal phase, and then the esophageal phase of swallowing. So I'm going to take the time and break down each of the phases so you have a clear understanding of what they are. When we think about the oral phase, oftentimes it is thought of as being two different steps because we have this phase where we are actually preparing the food and then the phase where we're passing the bolus back. So for reference, a bolus here would be, whatever it is that you're eating or drinking, the liquid or the solid. So the food would be placed in the front of the mouth where we are making it moist. We are chewing or doing the process of what we call masticating or mastication. And we're forming it into a cohesive bolus, and we're starting to pass that bolus back. Then the bolus here will transition, and it's passed from the front to the back. Now, there is some other anatomy here that I would like for you to start looking at as well. And that is the epiglottis. And I'm gonna talk a little bit more about that. And I just want you to notice the position that the epiglottis is in. It's in more of an upright position. And there seems to be space here between the back of your throat and where the epiglottis is. Now, at this point in the oral phase, we are transitioning from the oropharynx, which is here in the front, as I said, to the lower part of the back of your throat. As we continue to move, no surprise, that bolus is transitioning, and you can see here that the epiglottis has changed position. So what happens in the pharyngeal phase of the swallow is that the nasopharynx will close, okay? So when we're eating, we want to make sure, so if you can basically see here, this is your nose, right? And so your airway occurs in this space. You want to make sure that no food is traveling back through this space. So that means that this area is closed off when we are actively swallowing. Our airway is also protected. Here are the vocal folds. And at the point in which we are transitioning that swallow in the pharyngeal phase, the vocal folds will close, and you'll have a breath hold from about a half to 1.5 seconds. So remember before I said, this is a very quick process, about up to 1.5 seconds. And the vocal folds being closed helps us to prevent aspiration, and we'll be talking about that a little more later. Okay, the bolus then transitions, and then it goes into on its way down past the epiglottis because the epiglottis again retroflexes, and it pushes the food towards our upper esophageal sphincter into your esophagus. You'll often hear medical providers might refer to it as the UES, so we just use its initials, but that is a sphincter that needs to relax and open so food can transition. And then our final stage is the esophageal phase. This is where the bolus will move down. And this is by like a wave, like a peristaltic wave. Almost, you can liken it to if a snake was kind of squeezing food down, squeezing the food down. And after it enters into the esophagus through the upper esophageal sphincter, it's going to then finish in the lower esophageal sphincter. Now, the esophageal phase is a faster or slower, than the pharyngeal phase. It takes approximately 10 to 15 seconds, and it's an automatic process. It's not under voluntary control. I want to point out here, though, this is emphasizing that this is your airway. So we're breathing in. This would be your airway. And then right behind your airway is where we eat or where we swallow fully. That's our esophagus. So then that tells you there's just a close relationship between the pharyngeal phase, the esophageal phase of swallowing, and our breathing. So that's important for you to kind of hang on to and remember. So you've learned a little bit about, or you have learned what the normal phases of swallowing are. So we have the oral phase, the pharyngeal phase, the esophageal phase. What does it mean if you have a disordered swallow? Well, as professionals, we call a disordered swallow dysphagia. That is a dysfunction of the process of swallowing, and this can occur during any phase of the swallowing, and it can be caused by a condition that's impacting the nervous system. There are signs and symptoms that are very specific to someone with dementia Lewy body and suffering from having dysphagia. You may have difficulty chewing or manipulating certain textures of food, mishandling certain liquids. You may notice that you're having coughing during meals. You may pocket the food. So it gets in that oral stage, you're preparing it, but unable to transition it. So it kind of pockets in the cheeks, it can pocket in the back of the mouth as well. There could be a loss of appetite and possibly nausea and discomfort. Now, again, we've talked about the phases, but I want to get more specific about the common dysphagia disorders or the dysfunction of the swallow in Lewy body dementia. Let's start with the oral dysfunction. In this phase of the swallow, there's reduced ability to manipulate the food in the oral cavity. And I think I've already mentioned that, but it's to be emphasized that chewing or tongue dysfunction, for example, to transport the food or liquid backwards to the pharynx or poor bolus formation. So I kind of emphasized on that, but didn't pull out the emphasis on the tongue. The tongue has a lot of muscles, has a couple of primary muscles that we use to manipulate food, and the inability to take food and move it from the front all the way to the back of your tongue, back of your throat can be challenging. In the pharyngeal phase, there could be retention. So that means that there's residual material left in two different spaces. And you're going to see this because I have representations of this later, of the anatomy. And that is material will be left in the vallecula and the piriform sinuses after the swallow has completed. Another issue in the pharyngeal phase of the swallow is delayed initiation of the swallow. Now, what happens is, as you saw in the pictures before, when the food comes to the back of the throat, there should be an automatic trigger, but this does not happen all of the time, and that's why there's a disorder. It hits the back of the throat, which we refer to as the falcial arches, but then the swallow is not triggered. And then finally, which is a common occurrence, is penetration of the bolus into the airway, and we call this aspiration. So on the topic of aspiration pneumonia, I think it's worthwhile for us to just dive deeper into this and have a little discussion. So on aspiration pneumonia, this is a pulmonary infection. And this infection is resulting from any time you inhale any bolus type that has a bacterial rich material. And this will happen when it goes into the lower respiratory tract. Simply stated, it's accidentally having food or liquids go into the lungs instead of it going into the stomach. So what does that mean to us? It could be saliva, vomit, liquids, and foods or solids. And this is caused by the impaired swallow or even having an impaired cough reflex, because a cough will tell you that something is there. That's the signal. And the response to that signal is the cough. And when the cough is impaired because the sensory input is impaired, this can cause aspiration pneumonia. Because you can't expel, you can't get the food or liquid up out of the throat area and either re-swallow or let it go. Now, aspiration pneumonia can be silent, and I think I kind of alluded to that when I talk about the sensation where the cough reflex is not great. The person may not understand or know that there is food in their throat area, and that means that it's silent. They don't know it's there, and so they're not going to have a reaction. There's also such a thing called micro aspiration, and it's really as it is broken down. Micro, the meaning small, aspiration can cause aspiration pneumonia, especially when there is high bacteria. So that means oral care is important, and we'll be talking about that in this discussion a little later as well. So the microaspiration means that, small amounts of food or liquid can be penetrating and aspirating into the airway. This can happen over multiple times before there's any indication that the person has aspiration pneumonia. And then there's macro aspiration, where there's gross aspiration of larger amounts of food or bolus. And what we do know in Lewy body dementia is that aspiration in advanced stages may be inevitable. So I want to just take a moment to point out some things here on this picture here. And that is, you can see here the air to the lungs, as you did in the other photos, that food can enter by mistake into the trachea instead of it going down the esophagus and into the stomach. So this is what we're trying to avoid when swallowing. So you may ask, how would I know? What could be some other symptoms that I might have if I'm aspirating? Well, there could be chest pain, coughing or choking, being tired after eating, sometimes even during eating, and it can stop you from completing your meal. Having unexplained fever, shortness of breath, wheezing may occur, having a leftover breath odor, excessive sweating, excessive saliva, just in general problems with swallowing, confusion, and unexplained weight loss. So with dementia Lewy body, why do you actually have dysphagia? You know, what's putting you at risk of having dysphagia? I would like to discuss in this section the prevalence and the incidence of dysphagia in dementia Lewy body. And I want to discuss how these changes of swallow function occur. Okay. So the prevalence of swallowing disorders is 32% of patients with dementia Lewy body are reported to have symptoms of dysphagia. Swallowing dysfunction occurs in 92%. So I want you to see that big number and the disparity between the swallowing dysfunction, and then also the next bullet point, which is the pharyngeal dysfunction, is 88% of patients with dysphagia do have pharyngeal dysfunction. Because what we typically find, as we could see in the poll, right, is that many people don't realize that they have dysphagia because maybe they haven't been educated, the reason why you're here today. But when we take a patient and we assess them, we find out that there indeed is dysfunction. So, you know, we always promote having a swallow test early and as advised by your medical provider and your speech pathologist. So dysphagia in dementia Lewy body affects the autonomic nervous system and makes it difficult to tell automatic reflexes to actually work. The unconscious mind is unable to tell the body what to do. Just having dementia Lewy body does have an impact on swallowing. Why? Because there's a few things going on with this diagnosis, and that is bradykinesia, so that's slow in your thinking, hypokinesia, slow in your movement. Then there's sensory deficits, muscle weakness, and muscle rigidity. So think about all these terms, right? And think about, you need 30 muscles to make the swallow function work. So if the muscles are weak, that's obviously going to be a challenge. If the muscles are rigid, they're not going to be able to move enough and in the way they need to complete that quick movement of swallowing. And then if there are sensory deficits, this can cause the aspiration pneumonia. This can cause the ultimate dysfunction. This can cause an inability for you to understand that you need to cough because you will not be able to feel the sensation. Other impacts of dementia Lewy body on swallowing are confusion, hallucinations, which can lead to dehydration, malnutrition, difficulty taking meds. In this area, when I look at these descriptors, this really leads to understanding that there are some cognitive delays and cognitive issues with dementia Lewy body that can lead into this. And we'll talk just a little later about some management strategies if you or your loved one, in fact, have cognitive concerns. And here we are. So, the impact of DLB on swallowing and cognition. Think about this: not being able to remember to eat because of memory loss, the inability to feed self because those are instructions of hand to mouth and just knowing what to do, difficulty with concentrating, so the attention, ability to maintain their attention to eating a meal, difficulty doing more than one thing, so dual tasking, and difficulty with preparing a meal, ability to follow directions, understanding how to prep a meal, understanding the utensils to use, using a stove, using a microwave, etc. These are all things that may be impaired in cognition because we know cognition is our higher level of learning, our analytic thinking, our problem solving. What can happen because of these things? Well, a patient may have weight loss, dehydration, deconditioning, poor oral health, depression, because we know that eating and understanding what needs the process of eating and being able to go out and make orders at a restaurant, these things are very social. Eating is a very big part of our life, and so it can lead to depression. It can also lead to increased saliva, which we call saliuria. This is an accumulation of excessive saliva. We're forgetting to swallow, and the frequency, therefore, of swallowing saliva is decreased, and that's what makes it accumulate. In this section, I'd like to share with you who evaluates and who treats dysphagia and what can you do about it. So in this section, we will be defining speech language pathology. We will be talking about the role of an SLP and others who may be on your swallowing care team, and we'll discuss treatment and the management of dysphagia. So obviously, I know this oh too well because I have become a speech language pathologist. And in order to do that, you must minimally earn a Master's of Arts or Science degree from an accredited university. That means it's a university that has been endorsed by the American Speech Language Hearing Association. We then have a national exam called the Praxis, which we must obviously pass that. Following, we have a 9-month supervised clinical fellowship. And then we have to obtain state license for each of the states that we plan to work in. And we have to apply for something called the Certificate of Clinical Competence, or the CCC. We do have 2 advanced degrees, the Doctorate of Philosophy and the Doctorate of Speech Language Pathology. Now, there are many advanced training and certifications that speech language pathologists can achieve. Swallowing and swallowing disorders. Some of you may have heard of the Lee Silverman voice treatment. Speak Out is another one, and ultimately becoming a scope specialist. This is one of the things we need to do quite a few of our exams. So I share this with you so that when you see a speech language pathologist, you can make sure that they have the training that they need to work with you as having dementia, Lewy body. As a speech language pathologist, we prevent, we assess, we diagnose, and we treat. We treat just about everything. And I highlighted swallowing because that was what we were talking about today. And we treat children and adults. So basically, we treat birth until passing. We work in many, many settings, but you will probably meet with one of us in a healthcare setting. It might be in the hospital, rehabilitation center, a long-term or residential healthcare and home health. You may come and see us in a private practice scenario or may work with us via telehealth. Now, many of us work together to work with swallowing. It's just not the speech pathologist on an island of their own. We have a lot of collaboration. So I wanted to talk to you about those folks I collaborate with. My dietitian helps our patients to counsel on nutrition and healthy eating. If there's anything that we need to check to examine your mouth and throat and to conduct certain procedures, you might see an ENT or ear, nose, and throat specialist. A gastroenterologist will help if you have any reflux disease or they specialize in treating esophageal dysphagia. So speech language pathologists usually handle oral and pharyngeal, and we send to the GI for the esophageal. Most of you will have a neurologist, but they help us to evaluate and determine the underlying neurological condition that's causing your dysphagia. Our occupational therapist evaluates and treats challenges that interfere with the ability to eat, and I usually say from hand to mouth, dexterity challenges. Obviously, all of you, the large number of care partners that are here today, we work with you because you're a big part of following through with our recommendations. Our physical therapists help to evaluate and treat postural changes because it is important when you're eating to have the best posture possible. Our physician assistants and our primary care physicians are invaluable because they can screen for dysphagia and they can make referrals to the appropriate other team members. And our social workers, they support us, they educate, they counsel, and they as well refer. When we think about now, since we've talked about this care team that you'll be working with, speech language pathologists evaluate in what I would call a three-prong approach. And that is first, we do a screening. And in our screening, it's mainly, we can talk to the patient. We might give you a water, which we call a 3-ounce water test, and basically have you drink. We're looking, we're listening. And then we follow that by a clinical swallow assessment. And this is where we're taking your history, your physical exam, your oral motor exam, which is looking at the range of motion of the lips, the teeth, the tongue, and the palate. We're looking at the strength of them as well to make sure you can manipulate a bolus. And then we'll take a food intake assessment. When we transition to instrumental testing, if the clinical swallow study indicates that we need to go further, we have, you can see here, a plethora of assessments. 3 that I'm very familiar with and most speech pathologists are high resonant, the HRM, which is high resonance, for looking at the degree of pressure of swallow. Then we have the FEES, which is your fiber optic evaluation that's giving us a bird's eye of your swallow. And then we have the video swallow. Also, we call that modified barium swallow study. So we're going to do another poll here. You see 10 questions, and I want you to read each of these statements, and you're going to rate them on a scale of 0 to 4. 0 is no problem, and 4 is severe. So I want you to read these each and total your numbers and enter your number on the poll. So I'll help you just by reading each one. My swallowing problem has caused me to have difficulty with eating. Do we have that poll up? My swallowing problem interferes with my social life. Some of these got cut off, I'm sorry, on my PowerPoint. Swallowing liquids takes effort. Swallowing pills takes effort. Swallowing is painful. The pleasure of eating is affecting my ability to eat. When I swallow, food sticks in my throat. I cough when I eat. And swallowing is stressful. Is the last one. Okay. So why don't you guys hold on to those numbers? I'm not for sure if we have a poll for that for you to enter. But hold on to those numbers because that's something we can discuss at the end during our Q&A. Okay. All right. So let's move on and talk about swallowing assessments that are non-instrumental. We look and investigate and we listen. So this is the part of that three-prong algorithm where it was the clinical assessment. So here we will provide you things like water, maybe a puree consistency like an applesauce. We may give you pudding, cracker. We're going to ask you what things bring you the most challenge, and those are the things we're going to offer. Okay. And we're going to look and listen. Are you choking? Or when you swallow, does your larynx elevate and go down? So there's just a lot of things that we're going to be looking and listening for and making a determination. Do we need to move forward and do some type of swallow assessment? So as I had indicated earlier, these are three of the most common assessments that we utilize. You can see the first one, which is the FEES. It's giving us a bird's eye view. This is used with a flexible scope that goes through your nose and it hovers over the top of what we call the laryngeal vestibule. So we're able to see food from that point of view. We do miss a little bit of what we call the pharyngeal phase. We have a whiteout, which means the epiglottis comes over and then it occludes the scope lens and we're not able to fully see the pharyngeal phase. The second test is the modified barium swallow study or video fluoroscopic swallow study. Here you can see this is a lateral view of the swallow and you would be taken to radiology to be able to have this assessment and see the swallow from the side. And then we have the manometry, and the manometry is looking at how the pressure of the swallow is. So that means, is there enough peristaltic action and input to actually transition the food into the esophagus? So I wanted to start by helping you understand that bird's eye view, because we're going to look next at a FEES examination. So this would be the epiglottis, and this is what retroflexes to close off the airway along with the vocal folds coming together. So we have our vocal folds here. We have the entrance into the esophagus here. These little pits here are called your piriform sinuses. And so the whole action is this epiglottis closing over, the vocal folds coming together, and then this helps to keep the airway protected so that food can go down the esophagus, which is located in the region of the hypopharynx. Okay. Okay. Now, when you look at a modified barium swallow study, it's going to be from a side view. So first we had the bird's eye. Now you're looking at these same features. You can see the nasal cavity, oral cavity. You can see the larynx here. Okay. The epiglottis is here. The airway is here. And then this looks at the whole pharynx, which includes three separate sections: the nasopharynx, the oropharynx, and the hypopharynx. This gives us a little bit more detail because you're looking at the soft palate, the base of the tongue, the jaw, the only bone of the larynx, the hyoid bone. Here you can see that follicular space, which you couldn't see on the other film, and then the epiglottis here. Here are the vocal folds. So obviously here you do not want food to pass this way because this is the trachea. Instead, you want food going down the epiglottis. The esophagus. Okay. Because I don't want you to be surprised, we're going to look at a couple of laryngeal images. This, no, is not an alien. It's not a monster, and it's definitely not a female part. You are looking over the top. This is going behind the base of your tongue. So let's look at these spaces again. You have the vocal folds. You have the epiglottis here. This is the tongue. And you have your piriform sinuses. And this area here is the airway. Okay. These are the vocal folds open so that you can see the airway. These are the vocal folds closed, helping to protect the airway. Now, ideally, when the vocal folds close, you also want these regions called the false vocal folds to close. So next you're going to see a video. There may be a little bit of delay. It's a short video. It might be a little delay because I'm playing this on a platform different from Optimal. But I'm going to play this and you're going to see the laryngeal valving. So I'm looking for this patient to open and close their vocal folds. This patient is let me get my pointer off. We're going to take that off. Okay, so this was a Parkinson's patient, not a Lewy body dementia, but a Parkinson's. So let me see if I can get my and my pointer. Okay, there we go.
Good. Stick your tongue out for me. Good. Put it back in. Good. Hold your breath. Squeeze, squeeze, squeeze. Awesome. Now I want you to say E. Okay, wait 1 second. And E with the sniff in between. So it'll sound like this. E, look at me. E, E, E. Good. Now we're going to hold out a high pitched. And relax. Okay.
All right, so the two things that I did there, or three things, is I had him open and close his vocal folds so I can make sure there was no movement problems that were stopping the patient from doing that. Had him squeeze and hold. And then the high-pitched E is just really helping to show that there's actual laryngeal elevation. And you want elevation that's part of that movement for swallowing, is that the larynx rises up, we swallow, and it relaxes back to its normal position. Okay. Now I'm giving you an example of swallowing water and applesauce. Here to your right, you'll see that green substance. Now we use multiple things to trace our food so that we're able to see it. Some people will use white colored dye. In my practice, we use green dye. I've been in practices that use blue dye. This is just so we're able to have a contrast to see the bolus as it enters into the airway. It's very quick, so I wanted to make sure you had a still photo that you can see. This has just come from the base of the tongue and it's ready to then be transported into this area, into the esophagus. And this is water initially.
Good. Okay. And you can hand that back. Give me another swallow, and then we're going to get ready to take the applesauce. So swallow for me again. Good. Okay, half a teaspoon. Excellent. Give them a full teaspoon. All right. And then we'll be ready for the fruit. Beautiful. Good.
Okay. So this was a safe swallow. You see no residue left from this swallow. So this patient was able to clear the bolus completely. This is in contrast to what we would see on a modified barium swallow study. I don't do that currently at my facility. So courtesy of speech therapy practice, I did locate a video where you can see the lateral swallow, and it is going down to the esophagus and not into the airway. So this would be normal. You can see the person preparing the food and then emptying it into the esophagus. You can see that epiglottis moved. There might be a little bit of residue left in the in the base, so that would be in the vallecula area. You can see just a little bit left there. Okay, try to get this to move forward. Okay. So what we've done so far is we've talked about the different phases of swallow, why you think you're having dysphagia. We talked about how a speech pathologist is trained and how they would work with you to evaluate you. Now let's talk about therapy and management. Why would you want to seek swallowing therapy? Because you can improve. Because exercise is considered a form of medicine and it helps to keep you safe and allows you to maintain the joy of eating. So direct treatment exercises will be exercises to strengthen your swallow and improve the coordination of your swallow. Exercises to improve coordinating breathing and the swallowing sequence, breathing muscle strength, and having a more efficient cough. And ultimately to talk to you about management strategies. Management strategies are something that you may use the full duration of your diagnosis. So management strategies. First, eat when you're awake and alert. This will help you to be more aware and avoid aspiration. Try to limit all distractions when eating and keep your chin at a level that is either neutral or down while you're eating. Now, this is something that I believe a speech language pathologist, after evaluating you, would make that recommendation. We do need to see the swallow before we make a recommendation of what we would call a chin tuck or putting your chin down. It's good to start your meal with fluids before eating. We don't want a lot of fluids, obviously. We want to limit that maybe 3 to 4 ounces because water is needed throughout the day. It helps to prevent things like constipation, dehydration, good for when you need to get your blood drawn using an IV therapy, etc. Avoid foods with lumps, bits of things, or mixed textures. Instead, make sure your food is soft or smooth in a consistency as recommended by your speech language pathologist. At some point, there may be problems using your utensils. This is where I think the occupational therapist comes into play. But you can consider trying foods like chicken strips, fish sticks. These are things that are finger foods. If possible, sit in front of the person. So this is really for our care partners. Sit in front of the person, make eye contact with them, smile before you start eating, then start eating without talking. Hopefully, your loved one will follow your lead, but be patient, as you might have to do this for a while before it starts working. If your loved one is having problems eating, less food, portion size things out. Less items, only put 1 or 2 food choices on the plate. That will be very helpful. But in addition, there is one food if they really like it, put that on the plate and then put another food right next to it. It's best to get in the habit of eating right along with them. I mean, if you're not going to talk, praise the food. Not a long explanation like some of us like to do, but a simple explanation like, yum, this is delicious. Good positive reinforcement can be very helpful. There was a study that was conducted at Boston University, and I found this quite interesting, that patients eating from red plates, I believe because of the vibrancy of the color, consume 25% more food than those eating on a white plate. Just don't put food down in front of your loved one. Create that positive atmosphere, but we want to make sure the atmosphere that you create is not very distracting. So music, sitting near a window, but nothing with too much action going on outside. Distraction can occur, so think one task at a time. You do not want to set a situation where there could be any confusion, especially if multitasking is involved in that. If you can get your loved one to eat a small amount several times throughout the day, that could be helpful, but be realistic. You might have to resort to using something like Boost or Ensure. This can help supplement meals. 3 to 4 ounces at the most at one time is suggested because you're emphasizing on small things throughout the day. What did the person used to like to eat in the past? Now what you like, okay, is not of the importance. It's what the person likes. So we want to make sure that we're giving them things that will encourage them to eat because they desired and they liked them before. If your loved one has been diagnosed and has a cognitive decline, These are some tips to help them during mealtime. Alternate the temperature and taste within a meal. For example, sweet and savory food or hot and very cold foods or fluids. Offer sips of ice cold drinks before a meal or in between mouthfuls. These kind of things we're trying to help to trick the sensory system so that they can differentiate and might want to eat more. Giving verbal prompts, sharing swallow, it's time to swallow, maybe tapping them, touching them, whatever kind of cue you believe, or you can point to yourself, it's time to swallow. Try placing an empty spoon in the mouth between mouthfuls to help stimulate a swallow. I want to touch on oral care because earlier we talked about, aspirating anything with a high level of bacterial can cause aspiration pneumonia, the infection. Okay, so poor oral health status on top of having a diagnosis of pharyngeal phase dysphagia and having an already reduced immune system puts a person at higher risk of pneumonia. So I emphasize on keeping the oral cavity clean so that saliva is clean. Use an electric toothbrush or a toothbrush with a larger handle. This can help with dexterity. Use toothpaste that's high in content with fluoride and aim to brush and rinse after every meal. So I wanted to mention this because I know this can be a hot topic. It is a family's decision whether or not you use alternative means of nutrition. This is not something that should be pushed on you, but it should be advised. And again, I can't emphasize more that this is ultimately your decision, the patient and the patient's family. But I thought that it would be necessary in this presentation to at least introduce you to the 3 different types of feeding tubes. We have one tube that was placed through the nose, that is your NG tube, and 2 other that are more permanent, and that is your PEG tube and your PEJ tube. And so these are where you'll be fed alternately through those tubes. Keep this in mind. This does not mean that you're not at risk of having aspiration, right? Because you still have saliva content. You still will actively have some swallowing. And there's other complications such as there being infection at the site of the tube, especially when we get into the PEG tubes and the PJ tubes. So I wanted to at least bring this to your awareness, but wanted to focus today on managing so that you can still continue to swallow. So in summary, dysphagia is a common issue in those with Lewy body dementia, and it affects the autonomic nervous system, and this leads to impaired swallowing reflexes. About 30% of patients with Lewy body dementia have dysphagia symptoms, but most will experience dysfunction of that second phase, the pharyngeal phase of swallowing, which can lead to aspiration of food, and that can potentially cause a pneumonia. And honestly, it could be fatal. Managing strategies are the best way to make swallowing easier, and addressing dysphagia early can significantly improve the quality of your life. It can reduce the risk of serious complications. If you have any specific questions or need more details, feel to ask. And that's what we're about to do. Okay.
Oh my goodness. Thank you so
Yeah.
much, Dr. Freeman. That was incredible. Great job.
Thank you.
I learned so much. And there we go. LBDA family, use your reaction button at the bottom to show Dr. Freeman some love. Thank you so much.
Thank you, everyone.
They're a very wonderful group and always so appreciative. All
Yeah.
right, you guys. Yeah, let's take a second. I'm going to open up the questions here. And they're pouring it on. They like you.
And
Nice
I love
job.
them. I haven't seen them yet, but I'm feeling the love.
Excellent. So the first question that we have here, I thought is pretty interesting. So we hear this a lot. So this woman says that when her husband met with a speech pathologist, even though he was newly diagnosed, he was still in the later stages of Lewy. He was even going into hospice. And
Mhm.
the speech language pathologist tried to address and work with him on memory retrieval. but never addressed his swallowing. So, this audience unfortunately is pretty used to having to, I think, educate their healthcare providers,
Yeah.
unfortunately.
Oh,
So, any words of wisdom you would say when they go to see a speech language pathologist and they're maybe wanting to address swallowing, but they try to divert and go to cognition?
most definitely. I absolutely love when my patients and care partners come in prepared. Please use this presentation and use what you know to identify the things that are important to you. So that means when you come in and see a speech pathologist, you're going to say, you know what? I already know what speech language pathologists do. And I know what speech language pathologists can do to help me and my loved one. I know you can help with cognition and memory, but that's just not what's important to us right now. I want to make sure that my husband, wife, sister, brother, cousin, I want to make sure that they can swallow safely. I want to make sure that they're not aspirating their food. I want to make sure that we can communicate with one another. So whatever your idea of improvement is should be shared. And if that speech pathologist is not receptive, it's okay to get a second opinion. It's always
I
okay
agree.
to get a second opinion, but just come to your sessions prepared now that you know, right?
Absolutely.
Yeah.
Excellent. Thank you. An interesting question here, is biting your tongue while eating a possible cause or link to dysphagia?
Oh, most definitely, because you're having reduced sensation.
Mm.
If you're biting your tongue, then I would say something's going on with lingual movement or lingual size. That is something that the speech language pathologist can look at. One of the first things I do is what's called an oral motor assessment. I'm looking at the range of the tongue, the appearance of the tongue, the strength of the tongue. And so if you indeed are biting your tongue and it's consistent, I think that's something you need to share with someone on the swallowing care team, whether it's your primary care physician, your neurologist, and say, hey, do you think I should have a speech language pathologist look at that? And why does that keep happening? So I definitely think it can be a characteristic of having a challenge with the oral.
Excellent.
Mm-hmm.
Very interesting. I didn't know that. I learn something all the
Yeah,
time from you.
yeah, because it should stay out of the way. The tongue should be helping you. It should be have a pumping action, and it's actually helping you. Now, the other thing, Julia, though, I think we should bring up is that, how's the dental care,
Mm,
right? So if you have missing teeth, then that's another reason why you might be biting your tongue. You have to have matching upper and lower teeth, and that's what helps you with chewing. So I wouldn't be surprised if that's not a problem, or maybe if you have dentures and the dentures aren't well fit either, because then that makes everything a little bit off balance in the mouth when you're prepping food.
very interesting.
Mhm.
I'm learning so much today. Thank you. So we have another question here. So this woman's husband, she says, has been in a nursing home for about 15 months.
Mm.
He's got a lot of different aids to help with eating, and he has, assistance when he eats. But she says that, he has that constantly running nose that he's had for a long time. And she's wondering, should he have a swallowing test, even if he's got people helping him eat and things to help?
I'm wondering if he already had some sort of swallowing tests, because it sounds like he is at least on some diet level. I don't know if it's regular or not. So that would be helpful information for me. Now, runny nose when eating is not typically a sign of dysphagia. It can be more a sign of people having reflux. I know folks have runny noses. If he doesn't have a runny nose any other time, so if there's not any related allergies, post-nasal drip kind of issues that are being controlled, then I would err on the side of, if that starts up, look at the types of food that he's eating. So, like, say if she's there and he eats something that's a low acidic diet and it doesn't happen, then it's like ding, ding, ding. This could be a reaction to the food that he's eating.
Interesting.
So,
Okay.
wow. Yeah.
Yeah, lots of good information.
Yeah.
Now this individual's asking if you need to swallow a test that looks at your throat and esophagus, is there a formal name for that study?
Well, a lot of people do video fluoroscopic swallow studies, and they will span the esophagus. So we do have some esophageal screening assessments that we do, and we will look at that peristaltic action. We don't necessarily report it in depth. It is a screener for our GI physicians. So again, if your spouse or whomever is going to have a modified barium swallow study or video fluoroscopic swallow study, power up, ask the questions and say, will you be also spanning and looking at the esophagus? They're going to say yay or nay, right? And if you're suspecting that it's an esophageal issue and they say they're not going to scan down and look, then say, I'm wondering if he can also be seen by a gastroenterologist. So that's the situation where it would be two different tests, whereas a speech language pathologist really could, like I said, do it in one step.
Now, someone had a question, and this is a big problem for our folks with Lewy, any type of sedation. Do these tests use any type of sedation at all?
No, you do not have to use any sedation. The only thing sometimes people will use with the fiber optic endoscopic swallow study, we can use a little bit of Afrin as a nasal dilator to kind of open things up. Sometimes we'll use a little bit of lidocaine, but most people don't use anything. I mean, it does help with the comfort level if you're going to be doing a flexible scope in someone's nose. So a lot of times I'll just do the Afrin. You don't want any sedation anyways, because it can really, you already have a sensory deficit. We're going to say that there's likely a sensory deficit. And so you don't want to further exacerbate that by using any type of anesthesia.
That makes sense. Excellent. And an interesting question here. Does this condition affect dysphagia both equally for Parkinson's and people with Lewy?
Oh, most definitely. But it's going to happen sooner with somebody with Lewy body than it will with Parkinson's. Parkinson's, I would say the first trait we usually see in speech is the low volume voice. Right? So they have the hypophonia. But in Lewy body, we see swallowing problems starting much sooner. So that's how those two diagnoses differ.
That's very helpful. Thank you. Now, here's one that I think is really interesting. So this gentleman says his wife has advanced Lewy, and he's noticed in the last few months that she seems to have forgotten to swallow while she's sleeping. So she's getting that accumulation, and then he has to suction her. So anything else that can be done to kind of mitigate that problem?
Well, we don't obviously want his wife to have aspiration pneumonia. So the first thing I would say is to make sure oral cavity is clean. So before going to bed, there should be a good dental regimen. Okay. When we're asleep, it would be a challenge. I think what you're doing already is good, which is just making sure you're suctioning. Now, if you want to put yourself on a routine to wake up intermittently throughout the night to do more suctioning, that would be a family decision, obviously. But because of the reduced sensation or sensitivity, swallowing is less frequent at night and less frequent during the day. It probably is not changing as much. So I would say keep up with the suctioning, but just add a really good dental routine.
Now, do they ever do in any of your practices the Botox injections to the salivary glands? And any thoughts on those?
Well, Botox actually relaxes. So you have to be careful, what your aim is and what your goal is. In dysphagia, we typically don't Botox areas to help with dysphagia, but only in certain instances. So it's more so for someone who does not have the sensory issues. Okay. So there's a couple different levels. So I'm gonna back it up. We first talked about the nasopharynx, and I said the nasopharynx needs to close, right? So the food does not go back up through the nose, okay? So sometimes that area can be tight and remain tight. And we have Botox that area so that that area will open for you to breathe, and then it'll contract back for you to be able to occlude. When it comes to the vocal folds, that's the second area that needs to close, right? So the food does not go down the airway. And sometimes with patients like the video I showed, he had some, what we call atrophy of the vocal folds. So they were getting a little thinner. and we will go in and augment them. We won't Botox them, right? We'll augment them with like a Juvederm or a Restylane, because that plumps up the vocal folds and helps them meet in the middle instead of kind of being like this, okay? So that can help protect you and make you safe. But just remember with Botox, Botox is really being used to relax. So it can help with the rigidity of the muscles. But I haven't personally experienced someone who had the any of the muscles for swallowing Botox to relax them. I think that would be I'm just thinking would be a little bit of a challenge, because you have to get the right muscle and then the muscle still has to work. And so the dosing would be any dosing of any Botox injection is not direct science. It really isn't. You don't come in and you're like, okay, I'm a 65-year-old male and I weigh 125 pounds, and we know, okay, we're going to inject 1.25 units. It's just not an exact science enough to use it now, but it can relax some of the muscles that will help you. But doesn't necessarily restore the swallow.
Fair enough. And I had no idea, you guys, that you can, use fillers to get those big gorgeous lips, or I guess to help your I guess close
Yes.
better.
Outside
Little
lips and inside lips. Yes.
There you go.
Yeah.
So here's an interesting question. Dry mouth can really be a problem for people with Lewy. And does that, how can that affect swallowing, and what can you do to work on that?
Okay, so yes, most definitely. Dry mouth can be a result of multiple things. The disease process itself, it could be medications. So I tell patients always check your medication list to see if that is a side effect, okay? When you have dry mouth, there are things that you can purchase, and you guys probably already know these, like the Biotine, different sprays, just to keep the mouth moist. Having a moist mouth helps to form a bolus. So you want to stay away from very dry foods that you can't manipulate, crumbly foods. Always have some type of wet food, whether you're putting applesauce with something, gravy with something. You want to try to have foods that are just more moist, and that'll help to manipulate it better and swallow it down. The other thing would be alternating a liquid with a solid. So you eat your solid and then you alternate that. And again, because of dry mouth, good oral care is key.
That makes a lot of sense. Thank you. Excellent. Okay. Let's see. Here's one. So, her husband is in the later stages of Lewy, so cognition has, been impacted significantly. And so he's eating well, but he does have excessive saliva, doesn't seem to be able to swallow the saliva. So should he have a swallow test, or what should you do in a case like that with the extra saliva when they're not sleeping? So we'll spin on the same question.
Well, for the excess of saliva, that is something that we do sometimes, going back to the Botox. Some laryngologists will manage excessive saliva with Botox, especially when the cognition has declined. Many of the things that we do as speech language pathologists, or train you all as care partners to do when you have excessive saliva, are like cueing to swallow, setting a timer to swallow. And those are just things that can become a challenge, right? So that's where we might want to fall into having some medical intervention. So maybe consulting with your doctor, seeing if working with a laryngologist, and you guys hear me, I keep saying laryngologist, which is a subspecialty of ear, nose, and throat. So that's who you want to look for. Sometimes neurologists also do Botox injections. Just make sure that you are working with a professional who knows how to, do Botox and do it for a Lewy body dementia patient. So I would definitely suggest that. And that's outside of doing things like, suctioning or wiping the face, or cueing him to swallow, because obviously he's eating dinner or eating his meal. So he's swallowing upon food reaching there, but just not remembering and not feeling that excess of saliva is there. Yeah.
Excellent. And you covered a question here. Someone was asking if a laryngologist is a good doctor to see, and it sounds like yes for these kind of issues. Excellent. Let me grab another one here. So regarding oral health, if a dementia patient has a cavity, do you have thoughts on drilling a cavity or trying a conservative, approach to where you can avoid that drilling and having to have dental work done? Any ideas around that?
Exactly. Well, I can tell you, I don't know all of the options for dentistry challenges. I'm trying to think because I know we want to avoid anesthesia by all means. So I think that would probably be a really good question, better for a dentist than it is for me. I know they have different products for numbing and maybe being able to isolate the area where the patient's cavity is. But again, here, I would say when you're researching for a dentist, either going to LBDA as a resource or going to a dentistry. I'm not for sure what dental, if there's a website I would go on, but I would have those questions already lined up and talking to a dentist in your local area, because they'll know, these are people who deal with folks who have neurological impairments, those who can't handle. There are folks who just, even without dementia, Lewy body, they can't have anesthesia. So I would feel as a medical provider, there has to be a dentist out there that specializes in that and would work with you to take care of that. So again, until then, just good dental care, good high fluoride, flossing, and using any mouthwashes.
Excellent.
But not ones that will dry your mouth out, right? So no alcohol mouthwash. Yes.
Okay. Is that are some of the ones that have like a high alcohol content, like your Listerines and things like that? Or what are some of the ones to
Oh, they're
avoid?
drying. They're drying. So I know that Crest has one, the Pro Health one that has no alcohol in it. Some of the more natural ones, because the alcohol in it will dry your mouth out. I don't know if
That makes
anyone's ever
sense.
noticed, you gargle with Listerine or regular scope, then you're like, wow, I feel a little dry. It's because it's killing off bacteria, but it's killing it off using alcohol, which alcohol is drying.
Interesting. That makes a lot of sense. Or- Here's the question that I think is really good. So she's asking if there's remaining food in the oral cavity or the esophagus. They've been trying to have them drink some warm water to help kind of break down the food. Is that a good strategy, or is there something else you recommend to make sure that they're kind of clearing that the food out of the mouth and the esophagus?
Most definitely. That goes back to the alternating liquids with solids. Okay. So that's something you should do regardless. It can be any temperature because the goal is just to push it back. Okay. The other thing is making sure you're doing small bites and small sips. That way, if you're controlling the size, there won't be so much to swallow. Okay.
Absolutely.
And in regards to pushing it down the esophagus, the same thing. If it's small bites, chewed well, small sips, you're not going to have a lot of restriction unless there's something obviously going on with the esophagus that would not allow it to move.
Thank you. Thank you.
Yeah.
So a couple questions here around, and I think this is pretty good. If big and loud therapy is also helpful with swallowing issues. That's part of that spread of effects, but go ahead and
Yeah,
take that
most
one.
definitely. So, I've been around a long time because I did Lee Silverman voice treatment, think loud, be loud, or speak loud, before it was a certification kind of thing to do. So there is wonderful data. There has been a lot of research. They were first initially funded using an NIH grant. So I love what Dr. Ramick has done with this program. When you do those type of programs, it's talking about increasing sensory awareness, but more importantly, it's building your air supply. So it is really training good, solid efficiency between the connection of talking and breathing. And I believe I mentioned it at some point in the slide that you want to help with coordinating airflow with swallowing. It is a system because you temporarily hold, you open, and you swallow. So why Does LSVT big work and help with swallowing? It's the same mechanism, everyone. So we are going to be speaking through this area. We eat through this area, but we also breathe through this area. The more you can condition the system, the more it's going to help everything that you do in that system. So the better breath support you have, the better drive you'll have at the area of the vocal folds. And guess what? We need those vocal folds. They're strong. We need them to come together, not just when we're speaking, but so we can have a good, solid swallow. So does that program help with swallowing? Yes, and the evidence is there. So if you are using LSBT, I want you to continue to think loud and speak loud, right? Keep up your practice, most definitely.
Very good. And you guys, we do have a webinar that we did back, I think it was like February on Big and Loud that you can watch. And I mean, when do you get a twofer? When do you get to work on your vocal volume and your swallowing? So
Yes, yes,
yeah, such a
definitely.
great program. We have so many more questions we could answer, but unfortunately we're out of time. So on behalf of the Lewy Body Dementia Association, I'd like to thank you all for taking time out of your day to join us. And also Dr. Freeman for sharing your knowledge with all of us. This was so informative. I always learn so much from you.
Thank you. I enjoyed it.
Absolutely. As a reminder, you guys are going to get an email in about a week with a link for the recording of this presentation and also resources that we mentioned today in the webinar. We invite you to visit that landing page on the website to stay informed about what's coming up. And I just want to remind you that October is Lewy Body Dementia Awareness Month. So please visit our website, keep an eye out on your email for lots of special events and educational resources. Our next webinar will be on Wednesday, October 30th from 4 to 5:15 p.m. Eastern, when we're going to unpack psychiatric symptoms. It's like a big old up your stuff suitcase. There's just so much in there to talk about. And that's going to be during a live question and answer session with Dr. Shiadi Onike from our Research Center of Excellence at Johns Hopkins. So during October, you guys, you'll go to the Lewy Learning Center. We're going to have different lessons on mood, agitation, delusion, psychoses, and you'll be able to submit your questions there. So last but not least, take a minute to complete that survey once we close out of the webinar here. And I look forward to seeing you all again in October. Thanks again, Darla.
Thank you.
And thank you all. Take care.